everybody. I'm Jill, for those of you who haven't met. I'm taking today. And as an introduction for those of you who haven't met, I'm a clinical exercise physiologist. That's what my day job is. This is Freddie, who's our clinic manager. And she's also my daughter, so we're in a bubble. So that's why we can hug and stroke and do lots of nice things. So those of you living on your own, I'm sure, are desperate just to get in there with somebody. Before we do anything, I'm going to show you a video. When you look at pre and postnatal, I think it's something that we all get concerned about in the fitness industry. There's two elements to it, isn't there? There's the element of one of your normal exercise participants pregnant and therefore continuing to exercise during pregnancy, but also returning from exercise after pregnancy, returning from pregnancy to exercise. So that's a concern for all of you. There's also an ability for you all to enter into and advertising classes or sessions that are specifically for pre and postnatal, and that's a whole area of business that you can enter. You can team up with midwives where you do the mums and Mars classes or whatever they call them, and you can link with them. We've done that in the past where the midwife does her bit and then they all do an exercise session afterwards. So there's lots of opportunity if you decide to go down the pre and postnatal route. When I was at university and I was doing all my studies, I remember quite distinctly when I was doing my pre and postnatal studies, really thinking, I don't really know what all the fuss is about. Pregnancy is natural. Lots and lots of millions and millions of women become pregnant and millions of women carry on life after pregnancy. Until I really got into the study and we had a chap come in to lecture, and he was really interesting, and he said with modern medicine we take pregnancy for granted, and when a pregnancy goes wrong we think that that's a rare occasion, and actually he said it's reverse, and when you really study it in depth you get to understand that every single childbirth is a miracle when it all goes all to term and comes out the other side as a beautiful baby. So I want you to keep that in mind, and I'm just going to share screen with you. So that's my video. I'll just paste the link for you guys so that you can, because a couple of you have just asked if you can have the video. What I love about that video is when I watch it, and I never cease to feel the same when I watch it, which is when you see all that happening inside a woman's body, when you see it coming to term at 9 months, and when you see the amount of push against the spine and the amount of push through the pelvis, you can really start to understand the impact a pregnancy has on a woman's body. And I think as an exercise teacher, that's quite important, that we understand what's happened to women. And that was a perfectly normal birth. Somebody's seen us, they would just have you just had a baby, Karima. Yeah, you are a superhero, I can tell you. So it is an amazing video, and I do think it's a nice video because it's not graphic, as in you're not looking at a real pregnancy, but I do think it gives you that feeling of what goes on in the body, which I think is quite important. So let's have a look at some of that, and I'm now going to share the PowerPoint, and we're going to go through some of that in a lecture type format. Do feel free to ask questions. I thought a useful place to start, having had a look at that video, is really having a look at the trimesters. So we're talking about a female who becomes pregnant, and that's one of the good things about teaching pre and postnatal, is you don't need to worry about equal opportunities and sexual discrimination at the moment. We're just talking about a female body who's been carrying a child. So we talk about it as being in stages of trimesters. Now, I don't want you to overly get hooked up on the trimesters. You know, you'll see different time spans no matter where you look within a couple of weeks. And I also don't want you, when we start to look at the do's and don'ts, to think, well, you know, in the first trimester I must do this, in the second trimester I must do this, because I always think it's the woman that you need to look at, because people are very, very different. I've seen ladies who are pregnant who stay very small in the first trimester and don't have much change until into the second trimester and well into the second trimester. Then I've seen other ladies who pop out of the pelvis as soon almost as they know they're pregnant in the very early stages of the first trimester. So as well as understanding the trimesters, I think you need to take into account what's happening visually when you look and talk to that person. What were they like before pregnancy and what were they like during the pregnancy? So pregnancy can be measured in various points. First, they go from the last day of menstruation, or ovulation, or fertilization, and also with chemical detection, which is why we go for pregnancy tests. And when you get the pregnancy test on a stick and you test the urine, that's through a chemical detection. So the first trimester is considered to be 0 to 12 weeks. Second trimester is 13 to 28 weeks. And the third trimester is anything from 29 to 42 weeks. And this is pretty much how the body will change over that time. So just take a moment to have a look and just look at the posture and look at the shape and look as the baby grows, and think back to that video and think what sort of things are happening to the spine, to the center of gravity, to the weight shift. You can see it's going into a more lordotic position by the time you get into the third trimester. When you look at that, that's one of the big considerations in exercise, isn't it? As you go through the trimesters, how you're going to place your exercise participant, lying, sitting, standing. How are they going to be comfortable? How can we make exercise safe? If you're doing standing type exercises or you're a weight trainer, there's no reason to stop. But what happens to the center of gravity? What about lifting a barbell when you're into the third trimester? I want you to think about all of those things because your center of gravity changes. Now, all of you, I'd like to just stand up for a moment. I'd like you all to stand up, and I'd like you to go into a split stance. I want you to get your two thumbs and I want you to put them into the small of the back, into your lumbar arch, either side of your vertebral column, so you're on the muscles that run up the vertebral column. Now I want you to press quite hard with your thumbs. Come into that split stance, and what I want you to do is lean forward onto your front leg, and you'll feel some of that tension start to go off, which means the muscles are stopping working at that point. and you're starting to move into the ligaments. If you go back onto the back foot, you feel that you're getting quite a bulge into the thumbs, and I want you to just go from one to the other and feel the change in the muscle activation of the muscles either side of the spine. And then I want you to bring yourself to a point where you feel you've got tension in the muscle, but it's not forcing against your thumbs. And that's really where your centre of gravity is. So this is a really easy way of finding somebody's centre of gravity. And I get people in my session to do this, stick their thumbs in the back and just bring themselves to a point where they feel like their back muscles are working, so they're not hanging on the ligaments of the spine, but they're not working too much that they're really fighting to stay upright. So just play about with that. You've got to press your thumbs in quite hard. Okay, so this is just representative of that. So I want you to think about that when you're doing standing work. These are the postnatal periods. Now, one of the questions we often get asked, and we're going to come back to postnatal at the end, is when should somebody come back to exercise after pregnancy? Postpartum period is considered to be birth to 6 weeks. Postnatal is 7 weeks to 12 months. So somebody can be considered postnatal for the whole of that year. By 12 months, the body should be back to normal. However, I've known people go into a second year and still be considered bodily postnatal. So there's no easy answer as to when somebody should come back. So we generally say that they should come back to exercise possibly after this 6-week period. But I've known people who come back a little bit earlier than that, and I've known some people who aren't ready to come back then. It also does depend on what type of birth they have, and we're going to have a look at the different types of births momentarily and have a look and see what the impact of those is. So let's get a little bit more detail behind each trimester. When you start to look at each trimester and what changes in the body, I want you to think all the time, how will that affect somebody in my exercise session? So in the first trimester, the embryo is developing. Firstly, the brain and the major organs. Then the muscles start to develop, the ears form, and the fetus starts to move. The heart functions from about 6 weeks. The toes and fingers start to form, and the placenta hormones start to take over. So we start to lose the hormones that we had naturally, and we start to get really hormonal and get into the placenta hormones. In the first trimester, if somebody has a history of miscarriages, and they've had several miscarriages, we recommend that they don't exercise. In the first trimester, pretty much you can carry on exercising normally for most people, but it's about how the pregnant person feels. Do they have extreme fatigue? Are their breasts swollen and tender? Do they feel nauseous? Do they have cravings or an aversion to certain foods? Do they have mood swings? Are they constipated or are they frequently urinating? Are they getting headaches? Are they getting heartburn? And are they gaining lots of weight, or are they actually losing weight in the first part of the pregnancy? So all of these things need to be considered. As we start to move into trimester 2, and this is where I said to you, don't get hooked up. This doesn't happen on day 1, week 12, week 13 for trimester 2. Everybody has this development of the baby happen. It will be very different in lots of women. So we have the embryo developing further, where the hair forms. So they have this like furry hair that starts to form over. It's a soft downy hair, and it's called the lanugo. The sex becomes identifiable. The mother starts to feel movement. Their scalp hair starts to form, and they get the vermix forming, which is a kind of almost like a cheesy, milky coating that they start to get on themselves. And at 24 weeks, the fetus is viable. Into trimester 3, the baby starts to develop its fat layers, its organs start to mature. The head engages with the pelvis around about 37 to 38 weeks, and you can visualize that from that video. Mobility starts to get harder, sleep starts to get more difficult. They can get Braxton Hicks contractions, which are false contractions. They get a lot of pelvic discomfort, and the hormones start to peak, ready to relax everything and push that baby out. So there's a lot happening inside the body throughout those months. In considering what we do with exercise, we start with considering what sort of pregnancies they've had before, if any, what sort of development is happening. And as I said, on the pre and postnatal courses that you've probably done, you'll get lots of physiological changes about the woman's body as well. But in a 2-hour workshop, I don't have time for that. But if anybody wants information on that, I can send you some extra notes. Think about the baby developing, think about the woman's body's changing to accommodate it, and then we get to the birth. Now, I want to just have a look at the types of birth, because when we come to the postnatal period, for somebody to come back, this plays a big part. So normal delivery is when the baby's head engages with the pelvis. We have an opening phase of the pelvis and the birth begins, and the contractions dilate the cervix, and it opens to about 10 centimetres and allows the baby to come out. The head is delivered slowly, and the midwife will wait for the head to turn and then helps the first couple of shoves as the baby comes out, and the rest of the baby is generally delivered in one contraction. So that's a normal birth. So if somebody's had a normal birth, when they come to the postnatal period, you're probably looking at about 6 weeks for them to return to exercise. We used to say return to exercise when they have their checkup and released by the midwife, but a lot of authorities now are not doing those follow-up checks unless there's a reason to. So not all pregnant women now have that 6 and 12-week check that we used to have by automatic, if that makes sense. So then we have a forceps delivery or a Ventoux, and this is about 1 in 8 women who have an assisted birth. So the Ventoux is a suction cap, and the forceps just help the baby's head come out. It's a lot more common than we actually think it is. So 1 in 8 women. In fact, my mother tells me I was a forceps baby, but Now we have a breech delivery. With a breech delivery, obviously things are a little bit more difficult because the baby's not in the right position for birth and things can get stuck. So at 34 weeks, if a baby's in the breech position, a midwife might, or an obstetrician might try to turn the baby in order for the baby's head to engage. There are several choices still of birth if the head doesn't engage and turn. It could be a vaginal birth still, or very possibly it could be a caesarean birth. And this is an episiotomy. In terms of an episiotomy, they actually are going to cut the woman slightly in order to, they've turned the head, or the baby might be too big, but they basically make an incision to allow the opening to be bigger and allow the baby to come through. So again, if somebody's had an episiotomy or they've had a breech birth against a normal birth, when they return to exercise is going to be much later. With a caesarean birth, we tend to say about 12 weeks. So with a caesarean birth, because they've had an operation that's been cut through everything, then we tend to say 12 weeks. I have had somebody come back to exercise at about 10 weeks with a caesarean, but that is when they are cleared by the doctor. They have 2 incisions on a caesarean. The incision on the outside is horizontal, and the incision inside is vertical. So they have an incision that goes like this and an incision that goes like this. So it's quite a big operation. They get sutured, and if they get sutured well, it all heals well. Some people as well opt for a voluntary caesarean. So people have different desires, and we must respect all of that, and we must consider the type of birth in their ability to return to exercise. So just a brief whistle-stop tour of the legal and ethical responsibilities that we have as exercise teachers. So generally, fitness professionals should only record information based on disclosure from the client themselves or from direct observation. And that's quite important in pregnancy. So in pregnancy, you want to particularly use a pre and postnatal PAR-Q. Again, if you don't have an example of one and you would like one, I do have an example of one. It has a lot more questions on it. It has all the questions that we've just discussed. So it'll have all the questions about previous births or miscarriages if they've had them, what their fitness levels and everything are. It's also got a postnatal section for them to fill in if it's a postnatal client coming back, about what type of birth and any other issues that came from that. So I can share that with you if you would like the pre and postnatal PAR-Q. So this is the sort of information that we need to collect. Lifestyle, medical history, previous pregnancy history, previous birth history, activity history, attitude to exercising during pregnancy. Now, you might think that that's an odd thing to ask about, but there are two camps. There's lots of evidence to say that women benefit from exercising during pregnancy. There's lots of benefits that you will all know. They're more likely to have a more natural weight baby if they're exercising during pregnancy. They're more likely to be able to stave off things like gestational diabetes, lots of reasons for them to exercise. It prepares them for labour, so they're stronger when it comes to labour, which gives them an easier birth. There's lots of evidence from the Royal Colleges to support that, and again, I can give you that. But there are two attitudes, because some people still believe that exercise during pregnancy is unsafe. And you will always get those two camps. So the more conservative view would say exercise shouldn't be participated in during pregnancy, but the more modern view is to say that exercise should be participated in. And there's lots of evidence to support now that it should be. But if your clients, they believe that exercise might hurt them during pregnancy, then you're going to have to work quite hard on behaviour change strategies to get them to understand that actually it's going to be okay. Motivating factors, so are they motivated to exercise during pregnancy? Is there any preferences to the type of exercise? Are there any barriers to exercise? And you should do a sort of fitness assessment really with them. And by that, I don't mean take them on a Cooper run or anything like that, but just, you know, basic exercises to see how they are moving and how they cope with that. Now, interestingly, you get a lot of women who become pregnant who have never exercised before, who do believe they should exercise during pregnancy, and come to you and say, I'm pregnant, I want to start exercising. That's a very, very difficult question to answer. In the first 12 weeks of pregnancy, it's the most vulnerable time for most women. If they're going to have a miscarriage, it tends to be in that time. This is not fact now, this is my opinion, and I'm always careful about when I give you opinion. When somebody has a miscarriage, they become very internalised and look for reasons. And I wouldn't want my exercise session to be in that weighed up balance of, you know, what did I do in the exercise session? Did that cause the miscarriage? So I'd be very cautious in exercise in the first 12 weeks. So whilst we say that a participant in the first trimester can do exercise perfectly normally, I would want people to pull back, if they're a normal exerciser, to what I call a maintenance level of exercise. So whatever level they're at, they would go to a maintenance level, not an increasing overload level. So we'd stop progressive overload and we would come to just a maintaining fitness level. I'd also be quite cautious about impact and positions and things like that. And we'll have a look at that again in a minute when we look at the exercise side. In that first trimester, you've got to be really careful with that. And if you've done a good screening and they come to you and they say to you, I've never exercised before, and you want to start, I think that leaves you a little bit more open to trying to get to understand their body and what their exercise level is. So if I'm dealing with one of my exercise participants and I'm saying, well, I want you to pull back to a maintenance level, how can I do that if I don't know if that person's never exercised before? So any exercise you give somebody who's never exercised before is intense to them because they're coming from a sedentary background. I, with that, recommend that they generally take up a walking program first. So if somebody came to me and said, I want to start an exercise session, I'd say, right, what I want you to do first is I want you to do 6 weeks of walking, and then I would give them some pelvic floor exercises and some low-level abdominal exercises to try and get some strength in through the core, and suggest that they perhaps did that, unless I was running a specific pre- and postnatal class where everybody was starting at the same point and I could accommodate them. So I think absolutely recommend exercise, but if they're a non-exerciser, they've been sedentary all their life, they want to get fit because they're pregnant, I think you start them off on what I would call physical activity rather than an exercise program that has physical exercise goals.
Quite frequently, when I get people coming to my classes, and I'll have someone who kind of has called me and said, you know, I've never done exercise before, and I'm a yoga and Pilates teacher. If my class is a general class, I will quite often refer them to a specific pre- and postnatal class.
Yeah. It is, and I think it's important to encourage them to exercise, but I don't think it's right to take a sedentary pregnant person into a normal exercise class. It'll stress you out too much in terms of how much adaptation you would have to make. So the first key is safety. So there are some contraindications to exercise, and I want to look at those. Now, contraindications is quite a specific term. When we talk about something being controversial, it means open to discussion. When we talk about something being contraindicated, it means it goes against the skeletal structure and systems. So when we look at contraindications for exercise during pregnancy, we are talking about the fact that it would be dangerous for them. And as safety comes first, these are the things to look out for. So firstly, if there's any significant physical injury, any acute bout of illness or chronic underlying disease, the onset of persistent or recurrent localized pain, abnormal or heavy vaginal bleeding. So again, you'll find in our PARQ there's some questions about that. What are warning signs to look out for about maybe when you should stop exercise? The American College of Obstetricians and Gynecologists have identified this list: vaginal bleeding, dyspnea before exertion, so that's shortness of breath, headache, chest pain, muscle weakness, calf pain or swelling, preterm labour, decreased fetal movement, so if they were feeling the baby moving but it's not moving as much, and any amniotic fluid leakage. So some quite key things there that are warning signs that things are going wrong with the pregnancy. Now I've also put this list up for you. Now this list, I'm not going to run through it, but it has absolute contraindications and relative contraindications. Now, the difference between the two is this: absolute contraindications means that if any of these are present, you must cease exercise or must not exercise. Relative contraindications is the fact that you could exercise if you're with the person who is competent enough to exercise with you and they are able to do a full evaluation and assess you, and that they have made the decision that exercise is more beneficial than it would be to not exercise. So if it's more beneficial to exercise, and you've had a full assessment and you're with the right qualified person who can cope with any of these being present, then you could exercise. That's the difference between something that's a relative contraindication and an absolute contraindication. So you can see here on the absolute contraindications, there's quite a list: preeclampsia, fetal growth restriction, short cervix. So I'm not going to run through this because you'll have the copy of the list and you can go through it at your leisure, and you can almost keep it as a checklist. So you can go, actually, if there's any of this present, then exercise is a must stop. You can see here on the relative contraindications something like poorly controlled asthma. So that doesn't mean they can't exercise, it just means we need to give them a full evaluation, assess them and see whether it is appropriate for them to exercise, and that there's more benefit of exercising than there is to not exercise. So this list will be in your notes. When should we stop altogether? You know, something happens in a session and we want to know, should we carry on, should we stop? So if any pain becomes present, so if there was pain and there wasn't pain before, any vaginal bleeding, any dizziness or feeling faint, any rapid heartbeat, so if there's any heartbeat that's rapid, or somebody said to you, I feel like my heart's really beating, any difficulty in breathing, any chest pain, any uterine contraction. So even if you think it's Braxton Hicks, or they've said it's Braxton Hicks, I would definitely, if they're having that in the middle of the exercise session, not be doing it. Any sudden swelling, so if their hands swelled or their feet swell or their ankle and they suddenly swell, that's a circulation problem. You need to also stop exercise at that point. Any severe persistent headaches. One of the things about severe persistent headaches, it could be a sign of dehydration, and dehydration can cause all sorts of other problems during pregnancy. Any leakage or gushing from the vagina, any severe pain in the pubic area or the hips. So the pubic area is going to take quite a lot of pressure. We had a look on the back pain lecture about the SI joint, and the SI joint takes all the forces from the lower part of the body and distributes it through to the upper body. With that shift of centre of gravity and with the hormone relaxin being released into the system, the SI joint can move more than it should move, because the SI joint should be fairly locked. It's fairly restricted in movement. Although we have some movement, it's relatively small. It also needs to be even. We need timing on both SI joints. So any dysfunction in the SI joint, as it becomes more lax, will put more pressure through to the pubic area. And then they've got the weight of the baby all pushing down onto the pubis symphysis joint. If we have any pubis symphysis problems at all, then we would stop exercising. Any questions so far? Because I'm told you it would be a bit of death by PowerPoint. Yeah, good question, Cami. If they feel dizzy and stop and then feel fine within a minute or two, can they continue as long as they feel okay? I would say it depends on the exercise program, really. If they were doing something like Pilates and you were going to go to a lying down section, then I would say, possibly okay. But if you're in an up class that's moving, I would probably say go home and rest and come back on another day. Pubic pain, can that cause girdle problems? Yes, it can. Yes, so any pubic pain, splitting of the joint, and then you've got, the pelvis not only is unstable at the back because of the SI joint, you've also now got an unstable pelvis at the front, and that will also cause hip problems. So we'll have hip problems. It'll also cause problems into lumbar spine. So when we look at that area, we talk about it being the hip pelvic lumbar complex. And because they all move together in a lumbar pelvic rhythm, get problems in one area, you'll get problems referred into other areas. Okay, let's start to have a look at the exercise session. So let's just talk in general about various things, and I'll bring in some of the changes that happen and some of the do's and don'ts. So in terms of a warm-up, we firstly want to screen them thoroughly, and we want to make sure that we have all that information that we have on the pre and postnatal PARQ, particularly about pre-pregnancy, particularly about their fitness, about their movement, about their lifestyle, about their medical history, all of those things. We want to include mobility and warming up exercises. We want to keep that very general, and we want a much more gradual increase in intensity. So when you might have gone up like this with quite a fit person, I always think of intensity build up in a warm-up as being like a flight of stairs. If you think of gradually progressing intensity by getting moves bigger, deeper, wider, faster, higher, all of those extra muscle things that demand ATP and take intensity up. Think of each one of those as a rung on the stair. And with a fit person in your normal classes, you might run up the stairs. Nobody can jump from the bottom to the top, but your warm-up might be quite quick. Think about an older person warming up and they have to pause on each stair. Think about them walking up. And pregnancy is much the same. What I want you to do is spend a little longer on each step. Everything in our body is a delayed mechanism. So if you understand how oxygen comes into the system, you've got 21% of air is oxygen. It's got to come in through the nose and mouth, be pumped by the heart. It's got to come through the lungs, be pumped by the heart, circulate round, go through the capillaries, into the muscle, across the muscle membrane into the mitochondria, where it's got to be used in the combustion of ATP for energy. Muscle contraction demands ATP. So the more muscle contraction you have, the more demand you have. But the heart and lungs are a delayed mechanism. We've got to get oxygen from out here round to the working muscles, particularly the big muscles of the legs. On an average person who's relatively fit, your heart is going to be about 90 seconds in arrears of any intensity build-up. So I always think in a warm-up, if I looked at that 90 seconds, in a fit person, I might be able to warm up in about 4.5 minutes. I might have 2 or 3 intensity increases, and I might warm up in between 4.5 minutes to 6 minutes. But in a pregnancy, I want you to extend that to 10 to 15 minutes. So I want you to do a longer, more gradual warm-up. Does that make sense with everybody? I'm sure none of you would disagree with that. It kind of just makes sense. Then when we look at the cardio component, we still apply the FIT principle. We're still looking at 3 to 5 times a week. But we're going to drop the intensity down almost to what I call the fat burning zone. So we're going to sit at about 70 to 75% of the heart rate max. Remember, this is only a guideline. You have to consider people's age. You have to consider the level of fitness before they entered the session. You have to consider the stage of pregnancy. I always think in terms of the cardio work, pregnancy will be a steady decline of the cardio intensity and decline of length of time, but we want to maintain it. So if you've got a runner who runs, there's absolutely no reason they can't run pregnant. So you want to keep that running up. You drop it to a maintenance level and you don't try and progress it, and you just keep that ticking over. Once the baby starts to come out of the pelvis, then you need to wear a maternity belt. So there are some good ones. I've got a really good link for one. You get like a neoprene belt that'll just velcro under the baby, and if you're doing impact work, I always think it's worth investing in one of those to just take the weight of the baby during the session. What we want to do is medium to low impact, particularly in the second or third trimester. So by the time you get to the second or third trimester, you want to reduce the impact right out. And then you want to make sure, if you're using machines, that they're quite fit for the mother, because obviously the mother's going to get bigger. You don't want to be getting them into tiny machines. You want to reduce complexity, impact and speed over the course of the pregnancy. So if you're an exercise to music teacher, you want less turning, less complex choreography, because remember, one of the big hormones that's released throughout pregnancy is relaxin. We have progesterone from the uterus, ready for the uterus to relax and for childbirth, but relaxin is the big ligament relaxer. It relaxes all the joints, ready for the pelvis to shift. So as we go up into the second trimester, the placenta takes over and starts to give out all of those hormones, and ligaments will be a lot more lax. So if you're getting heavier and you're full of baby and fluid and you're turning a lot, then you're going to possibly overbalance, stretch ligaments, put joints into positions that they can't go in. So as you get into end stages, particularly of second trimester into third trimester, you want to ensure that you take all of that out. Moderate pace and speed, and you want to aim for 20 to 30 minutes. You want to avoid long periods of standing because of that fluid build-up that they get. Overhead repetitive movements. You want to look for comfortable positions with a good centre of gravity, and you want there to be no nausea. So obviously if they're feeling sick, you don't want them to be exercising at that point. So all of those things are very key guidelines for cardio work. In terms of teaching guidelines during the cardio work, you want to educate them about the benefits and risks and purpose. You want to communicate through them all the time, asking them, how does it feel? How does the baby move after exercise? Just check with them all the time, observe them, make them hydrate, and don't work to the point of fatigue. One of the other things I would say about cardio work is, remember, the baby is suspended in fluid. The baby will be 2 to 3 degrees warmer than the mother. So it's one of the reasons we do this gradual warm-up, is so that the baby doesn't overheat. But also when you come to cool down, the baby will cool down slower. So if during a cardio component you get the mother too hot, the baby could also overheat, and then it'll take longer for the baby to cool down than it will the mother. So again, just keeping this maintenance level is key. So in the first trimester of cardio, avoid any hot or humid conditions, ensure they've got adequate food intake, avoid massive buildup of lactic acid. So again, we're not going to go to that low overload point. Avoid the Valsalva maneuver. So the Valsalva is when somebody holds their breath. When somebody holds their breath, it changes the carbon dioxide shift in the blood, and what happens is the blood pressure will drop. So it's what an anaesthetist looks for in an operation. So in pregnancy, you want to encourage breathing throughout. Again, why something like Pilates or yoga is a perfect form of exercise. But review the activities with them every week. And then as they start to change shape towards perhaps the end of the first trimester, you can start to make further adaptations. Into the second trimester, start to review some of the positions. So review anything that goes overhead. So if somebody's doing a lot of overhead work, it doesn't mean you can't do it. You just don't want to over repeat it. Review any machines that you're on, and review the program in terms of positions and joint stability, because as we get more relaxing into the system, we're going to get more unstable joints. So for instance, if you're somebody who uses maybe a Stairmaster, I might take them onto a treadmill instead into the second trimester, because we don't have that big joint work that's going to go through the knee, the hip, the foot and ankle and the hip. Into the third trimester, you want to reduce everything right down to about 50% of their workload. So you can see the line of overload coming like this throughout the trimesters. So by the time they get to the third, you want to be about 50% of where they were at the start of the program. Now, in terms of muscular strength and endurance, there are also some guidelines. So this is muscle conditioning work. Again, we apply the FIT principle. We want 3 to 5 times a week, so we have 24 to 48 hours of recovery. Resistance training needs to favour the endurance continuum rather than the strength continuum. So if you've got somebody who's a big weight trainer, they can carry on weight training during pregnancy, but you want to, again, take it down. I would say in the first trimester, maybe go to 100% of what they were lifting, but not increasing it, so just maintaining where they were. In the second trimester, you're going to drop to about 80% of their lift. And then in the third trimester, you drop to 50% of their lift. And when I talk about 50%, I'm talking about the DeLorme 10 rep max. So you're going to about 50% of their 10 rep max lift. Now, again, we have to think about position through the 3 trimesters. So first trimester, you might want to be standing and doing all the positions as you would normally do. But as that centre of gravity shifts into the second trimester, you might want to change to more of a split stance rather than a set stance. Towards the end of the second trimester, we eliminate any lateral movement. So because of the pubic symphysis again, and we don't want to get the disorder of the symphysis pubis, we call it SPD. We don't want to aggravate it and inflame it and split it. So we avoid lateral movement once we come out of the pelvis and we start to get a little bit bigger. So towards the end of the second trimester, avoid lateral movement. Third trimester, definitely no lateral movement. Seated exercise, great. Then we go to lying exercise. So this is things like Pilates and yoga. From the second trimester onwards, we want to avoid fully supine exercises or fully prone exercises. So we avoid fully supine exercises because of supine hypotensive syndrome. So what happens if somebody lies on their back is that the weight of the baby's pushing up into the thoracic cavity, and the weight there can make the mother get short of breath, go dizzy and faint, and their blood pressure drop. So for any lying work in second trimester, we go semi-supine. So one of the things I get everybody to do in a pregnancy class, I just put it on there, is to bring a pillow and a blanket. I bring a pillow and a blanket. And what we do is we put the pillow under their back and we fold it, maybe with a block underneath it, and we make them semi-supine. So we put them in a semi-lying position. If they've come out of the pelvis and they're getting quite big, obviously you want to come off lying prone, and you want to come up onto all fours to do the exercises on hands and knees. And then you'll pretty much keep that all the way through pregnancy. So semi-supine because of supine hypertensive syndrome, and you want to go to prone all fours into 4-pointer position rather than lying on your stomach prone. What we do want to concentrate on in any work is form and pace. So we want good form and we want an effective pace. So we want things not to be jerky or quick. Remember, we've got relaxing in the joints. We want things to be smooth. Really focusing on that form and pace. No holding of the breath, because again, if we hold the breath, we'll get the Valsalva effect, which means you get the carbon dioxide shift in the blood, you'll get the blood pressure dropping, and then everything will start to go awry. The flexibility component. The aim of flexibility is to increase the range of motion in or around a joint. Now, what I would say is during pregnancy, there's no need to worry about that, because certainly around the hip and the pelvis, suddenly people feel really mobile. So, you know, they've got lots of relaxin in their system, and suddenly they can do wonderful things with their legs that they couldn't do before. All in preparation for childbirth, of course. With any stretching or flexibility, again, you want to adopt the same thing, which is to maintain it rather than push it. You don't want to be doing developmental stretching or PNF stretching or isometric stretching. You just want to be doing short maintenance stretching, taking muscles back to their pre-exercise length. And I would have a tendency to orientate it around mobility, so more dynamic stretching in a mobility range than I would holding a stretch itself, because we are going to get very mobile anyway. Think about the transitions again. You want them to be in a nice, stable position. So I would be doing most of my stretches seated. If I was standing, I would be looking for that center of gravity again, trying to make sure that I don't have that big shift forward as we go through the trimesters. And then lying, again, you don't want to be supine and flat. You want to be semi-supine, and basically then coming to knees or standing, because what you don't want to be doing is lying on the floor on your stomach either from second trimester to third trimester. So these are the changes that influence the performance in relaxing. Use pillows and props. So with a pillow, I do two things with it. We can put it into semi-supine, so to stop the supine hypertensive syndrome, which is SHS. But also when we come to side lying, which is a good position, so if you wanted to do something like a quad stretch, you don't want to go lying on your stomach, you go lying on your side. I also then use the pillow to put under the bump sideways. So once you're into third trimester, put the pillow under the bump lying sideways, because obviously lying sideways you're still going to get this pull that way, but you can put your pillow under the bump sideways. We've talked about the posture changes. Look for heartburn. If anybody's got any heartburn, you want to kind of open up, really kind of open up that posture, trying to help them, because the heartburn comes from the baby pressing into the stomach and vital organs. Think about getting up and down to the floor. So be very careful about how to do that. You can do what we call backward chaining. So if any of you have ever done any backward chaining, so I'm just going to show you some backward chaining. So backward chaining is something we use in the older population, and you can also use in the latter stages of pregnancy when somebody's big. So when you think about a movement, what backward chaining is to break that movement down. As we know, sitting down and standing up is a squat. Anything to get down to the floor can incorporate a lunge. So if you're working on a one-to-one, what's great to do is have some support. So if I wanted to get somebody to the floor, so I would bring the hands to here and I'd step them back into a lunge position here. And then gradually what you do is you just take it down to a lunge and you bring them down to one knee. Then you bring them down to the other knee and then you walk the hands down to the floor. Okay, now if you don't have a chair to do it, I'll show you how to do that in a second. So to reverse it, you come back up to the chair, you bring your hands up to the chair, you bring your hands to here, and then they use the chair to come up out of the lunge position. So backward chaining is just about lunging. So if you don't have a chair, so basically you would come to the lunge position and just put both hands on your leg here, and then you would just come down to the lunge here, bring it here, and then walk your hands down. And then bring your hands back towards the legs, bring your hands up to here, bring one leg in front first, put your hands back on the leg and use your upper body and lower body to get back up from the floor. So it's a technique that we use. I've got a little lesson plan with it on if you want it. You have to make a list of what you want. Okay, so think about that getting up and down and think about the concept of backward chaining. Quite happy with the 3 trimesters because I only want to do about another 15 minutes. I know it's a lot in a short space of time. There's a lot more to it than I've given, but they're really key guidelines for you. I'm going to jump now into the postnatal period because I think that's always a big interest to people. For the next 15 minutes, I just want to do the postnatal period. There's a little bit more on the PowerPoint than I've jumped, but I've spoken a lot of it, so you will get that as well. So there are some key benefits to postnatal exercise. So this is somebody coming back after the pregnancy. So improved posture, local muscular endurance, increased stamina, increased energy, increased metabolic rate, increased weight loss, improved body image, increase self-confidence and reduce anxiety. For a lot of mothers, it's getting out of the house as well, getting into an exercise session and going and meeting other mothers and joining in, and there's a massive social aspect. So what are the considerations for the postnatal period? What should we have a think about? Relaxing is still an issue. So if relaxing is still an issue, it can be there for up to 12 months. Now, the best person to tell you whether relaxing is still in their system is the mother. I think throughout pregnancy, you need to be communicating with the mother quite a lot. I've known people at 12 months say, they still feel, more flexible than they were. But other mothers will say to you, actually, they were really flexible, but that's kind of gone now. Now, that flexibility and that relaxing could have left them with many issues. It could have left them with SPD, which is symphysis pubis dysfunction. It could have left them with SI joint issues, which in turn could have left them with lumbar issues, which could have left them with hip issues. So there's a lot of issues from pregnancy that are caused by this relaxing issue. There's also something called diastasis recti, which is where you have a split down the linea alba. And I just want to show you all how to check for that. So this is a big check. So I'm just going to stop sharing screen again. I'm going to borrow the lovely Freddie. Now the linea alba, if you've had a very big baby, they could have had a split. Now the linea alba is in layers, particularly through the abdominal aponeurosis as well. So the split might not be all the way through. Sometimes they can have a deep split, but the more superficial linea alba is there. Sometimes it can have gone all the way through and just the skin there. So what you're going to do is you're going to get 2 fingers, and the mother can do it themselves or you can do it. You're going to inhale, tuck the chin, exhale, come up to the crunch position, and from the belly button up to the breastbone, you're just going to push down 2 fingers like this down the linea alba and see if there's any split there. If it's wider than 2 centimetres, they're not ready to return to any kind of abdominal work, and just be a bit careful with that. So you're just going to check it. So just get down and try that yourself. Just inhale, tuck the chin, exhale up into a crunch, 2 fingers. You can get the mother to do it, just put the fingers on and get them to press down and tell you where you feel a split from the belly button all the way up to the breastbone. Now if you want to, you can also just go slightly below the belly button, because you can also just get a slight split just below the belly button. You shouldn't have any. So relaxing and the diastasis recti are 2 big considerations for returning postnatally. Did they have a C-section, or have they been split in any way? What kind of birth did they have? If it was normal, great, get them back at 6 weeks. If it's a C-section, probably wait till 12. Certainly wait until their stitches have healed and they've been cleared by the doctor. Now, one of the things to bear in mind with a C-section is that they'll have scar tissue. I want you to think about darning. So those of you that perhaps are too young to know what darning was. So it's like a repair. So when we repair something, we have collagen fibres laid down in a tough fibrous matrix. So where you're getting scar tissue along that scar of the caesareum, that's going to be tougher than muscle tissue itself. So whenever you have a tough bit like a darn in a sock, you have a weakness either side of it. That scar itself won't go. What will go is either side of the scar. So when you start to get a build-up, and especially if somebody's had multiple C-sections, you get a build-up of scar tissue, it can prevent that nerve innervation through to the abs. So they can lose a lot of control through the abdominals and therefore a lot of control through the core, and they just can't activate it at all. So what does sometimes need to happen is you need somebody to do some manipulation work and help break down that scar tissue and start to get that moving. But that wouldn't be our job. We have had some clients here, a couple of postnatal clients, who have had to have that re-operated on and the scar tissue removed. Are they breastfeeding and lactating? So, their breasts will be quite big, full of milk, quite painful to lie on the front. They'll also have some seepage possibly. They'll possibly need to pump from that. All sorts of things going on. Also, in terms of calories, you need about 20% more calorie output when somebody's breastfeeding. So think about that in terms of your energy output in class or a session. You've got your normal calorie output for metabolism, for your basal metabolism, your physical activity. You've then got your exercise on top, and you've got about 20% extra for breastfeeding. So think about that in terms of your calories. Think about post-pregnancy posture. Have they got mobility back in the pelvis? What are their abs like? What is the core like? Core stability and pelvic floor is the big thing to be working on, would I say. Again, if you start weight training or cardio, an easy way to think about postnatal training is think about where they stopped, take off 20 to 30% load and build back up again. So wherever you stopped at trimester 3 in terms of your loading, be it cardio, be it muscle work, take off 20% and start to build back up from there. Because wherever they stopped, they'll have had this, the childbirth, and we saw the video of what that does to the body. Then they'll have had this period of not doing any exercise through the childbirth itself. And then you need to start to build up from there. So that extra 20% pullback allows you to build from there. But from there, you're just doing exactly the reverse of what you did during the pregnancy and building it all back up again to get them to normal fitness. So we want to, again, in weight training, look at 50% of your starting point of the previous Delorme method. Is there any symphysis pubis dysfunction? If so, that's got to settle. We've got to work with that, and there'll probably be in treatment for that with something like a physio. Have they had any carpal tunnel syndrome? We didn't talk about carpal tunnel syndrome actually in the 3rd trimester. One of the don'ts in the 3rd trimester is not to put pressure through the wrist. So where you have the tendons and ligaments that come through to the hand, they come in a sheath tunnel called the carpal tunnel. Because of the extra fluid we carry during pregnancy and some irritation into the nerves, we get a closing down of the carpal tunnel space, and basically what happens is you get carpal tunnel syndrome. So it's very painful on the hands and fingers. So in the 3rd trimester, even though you're on all fours, don't put any pressure through the wrist. Maybe have their hands on blocks. If you're in a press-up position, you know, maybe go to straight wrist on a bar rather than doing push-ups like this. And then when you return postnatally, start from that point as well. And if they've had carpal tunnel, you need to just make sure that that's gone before you go back to using the hands, particularly if they're breastfeeding and also they've got a baby who's keeping them up at night. Just look out for fatigue. So lots of guidance there on postnatal. I've broken that guidance down a little bit more into some different PowerPoints for you here, which you have copies of, all of about what I've just talked about. So I've talked them through even though they are there on PowerPoint. So I'm going to come out of the PowerPoint now, and we're going to go into the Kegel exercises. Any more questions before we do? Anything to consider for hernias? Now, it depends where the hernia is. So if it's an inguinal hernia or a belly button hernia, it depends where the hernia is. But again, it would just be about building up core stability, perhaps isometrically first, making sure that we can build a really strong core. Key for me during pregnancy, all the way through from day one, and it's the biggest thing I refer people's lesson plans for when they submit them on the award, is they don't consider from day one activation of the pelvic floor, activation of the deep intrinsic core. So when we look at the core, and this will protect hernias and recovery from pregnancy and also stabilize the spine during pregnancy. The core is a number of muscles, so just let's have a look at those. Firstly, we have the pelvic floor, which is the bottom of it. The pelvic floor is a hammock-shaped muscle that's got a deep ligamentous structure that sits inside the pelvis. It's a 2-layered muscle. It has 3 passages of opening. It's going to take a big bashing. We saw that in that video. It's the base of the core. We're going to come up the sides and we have internal oblique. We're going to go across the front and we have transverse abdominis. We're going to come to the lid of the core and we have diaphragm. We're going to come round the back and we have quadratus lumborum, which are your lateral stabilizers. You're going to come in towards the spine, you have multifidus, and you have deep spinalis muscles running up and down the spine. That's the tube. Then we have a connection from diaphragm through to the pelvic floor through iliopsoas. So iliopsoas comes through the pelvic floor, up through to the ribs into diaphragm. So they're connected by the aponeurosis there. Now, what happens as well is that the deep multifidi sheath is connected to the ligaments of the spine. So if we've got any deep core instability, we then also have some spinal instability. If we've got any SI joints, they're also going to impact onto the posterior ligaments of the spine. So the SI joint affects the core stability, the ligaments affect the core stability, and that whole thing can get turned off in pregnancy. So what we want to do throughout the pregnancy is make people really aware of their pelvic floors. People say to me about abdominal work. I've got to say there's no point doing abdominal work in pregnancy because the abdominal is going to relax. The abdominal is going to relax. There's nothing going to make that abdominal stay in. Not if you want the baby to grow and come out of the pelvis. But core stability on those deep intrinsic spinal muscles is probably vital. So from day one, I expect to see this becoming predominant and taking a dominance in your lesson plans. Now, Pilates teachers, yoga teachers, I know that you'll have the core in there anyway. But the Kegel exercises is one of the ways to introduce those pelvic floor movements into everything else that you do. So you're just standing and you're in a warm-up. So I just want you all to stand for a minute. Think about that tube of muscles. Now, the deep intrinsic stabilizing core has 3 unique properties. It has the ability to co-activate neurally. So when you activate one part of it, you'll activate most of it. So if somebody can't activate their pelvic floor, then they've no chance whatsoever of stabilizing the spine. So we need to activate the pelvic floor, which will activate TVA, which will transmit through iliopsoas up into diaphragm, all sorts of things. So that's its first unique property. It has the ability to co-activate. Its second property is it has the ability to endure. So once activated, it should be able to maintain activation throughout other movements and activities that you do. Its third property is it can do it on a forward feedback loop or a reverse feedback loop neurally. And what that means is if you go to make a movement happen, your brain should co-activate the core to protect the spine. So neurally it's switched off and we haven't activated it. That's a forward feedback loop. So before you do the movement, the brain should switch it on. Let's say it doesn't and you go to do a movement, so the brain should then recognize that a movement's happened and switch it on through the reverse sensory feedback loop. And then it should co-activate. But of course, throughout life, and certainly through pregnancy, that's all switched off. So let's wake it up and see if we can activate it. So one of the first things with the Kegel exercises is can you activate your pelvic floor? Can women not only activate it, but also relax it? So I want you to visualize the pelvic floor, and I want you to visualize it as the infinity symbol. So visualize it as the infinity symbol or the figure of 8. Going from your front passage to your back passage. So visualize that figure of 8, that infinity symbol. Now, where you see that join of the figure of 8 in the middle, so I want you to try and contract and trace around that figure of 8. And where you see that join in the middle, try and draw that join up inside you and draw up the pelvic floor. So that's the first stage of the Kegel exercises. Hold it for about 5 seconds and release it. Now, I'd like you to do that 5 times. So visualize that figure of 8, go around the figure of 8, come to that middle portion and draw that middle portion up inside you. Breathe and relax it out. Now we're going to do the second part of the Kegel exercises, which is to practice breathing. So Pilates teachers now, you might have a meltdown. Yoga teachers, you'll probably love it. And those of you that are in the middle of all of that will probably wonder why we're doing it. But breathing, as you know, is quite important. At the end of the day, just breathe. But what I want you to do for the Kegel exercises is as you breathe in, I want you to push your belly out. And then as you breathe out, I want you to draw your belly in. See, yoga teachers get that, don't they? As a Pilates teacher, that kind of goes against my breathing mechanism. So just do that again. As you inhale, push your belly out. And as you exhale, draw your belly in. Now this time, go back to your infinity symbol. I like the infinity, think of it as an infinity symbol, because that's how I like to think of the pelvic floor, as infinity. We've got to kind of get it activated. So I'd like to go around your infinity symbol again, come to the join in the middle, draw it up inside you, hold it, and then I'd like you to inhale, push your belly out with the pelvic floor held, and then exhale, draw it back in, and then release the pelvic floor. Just try that one more time. So go around your infinity symbol, draw that infinity symbol up inside you from the middle point, inhale, push your belly out, exhale, push your belly in. So that's the first part of the Kegel exercises. Now the second part is you've gently released it. Now it's as important to be able to relax the pelvic floor as it is to activate it, because often at the end of pregnancy, and I've known with some people who've worked a lot on their pelvic floor, they can get an overly tense pelvic floor, which gives them as many pelvic problems as a relaxed pelvic floor.
So just in case you were worried about having too weak a pelvic floor, there's also the possibility of having
too strong a pelvic floor. So if you, and I think it's worth doing the Kegel exercises. So you could just visualize your warm-ups again and think, well, where could I put that in? You could do that whilst you're doing a posture check at the beginning. Just get that whole Kegel feel going and introduce it right from the word go. The reason I think you should bring it into the early part of pregnancy is because in that period where they've had the baby and they're waiting to return to exercises, I would set them the Kegel exercises to do. Because if you can set them activating the pelvic floor and doing that breathing mechanism, then you can get them back to work much more quickly. So, okay, that's the first stage. Now, the second stage is the ability to force the pelvic floor away. So whether you're seated, standing, just do that again. So think about your infinity symbol, draw it up inside you. Inhale, push your belly out. Exhale, bring it in. And then throw away your pelvic floor. So force your pelvic floor away.
Caution. If you've had children, be careful.
Yes, and if you need a wee, go for one now. So Megan, you're having trouble feeling your figure of 8. Yeah, and it is a neural thing to try and get it activated. So, and that's the problem. A lot of people, a lot of women particularly, don't know if they are activating their pelvic floor or not. What you get is a buttock squeeze. You get lots of other things going on. Right, let's go to the Kegel exercises. Right, so that first bit is about perfecting your technique and finding it. So the first one we're going to do is a pelvic tilt. So now, if you want to do this as part of the bridge, feel free to lie down on the floor and do it as part of the bridge. If you want to do it seated on a chair or seated on a ball, feel free to do it seated on a ball. But we're going to do the pelvic tilt. So if you want to do it standing, you can stand. So firstly, tilt your pelvis forward and back. As you thrust forward, now when we talk forward and back, when I say thrust forward, that's your pubic bone going forward, so you're actually going into a posterior tilt. But when you're talking to the public and you say put your naughty bits forward, basically. So as you thrust forward, contract your abs and your glutes and breathe out. As you release and tilt back into a lordotic position, inhale. So let's just try that all together. Just get that pelvic tilt going, just relax your knees and just tilt it forward and back first, yeah? So as you tilt forward, contract your abs and your glutes and breathe out. And then as you go back, inhale. And draw up your figure of 8. As you come forward, exhale. And as you release, go backwards, inhale. And do 8 reps. And as you go backwards, draw that pelvic floor up from the center of your figure of 8 or your infinity. So think about exercises you can put that into. You can put it into seated ball exercises. You can put it into your warm-up again or your prep phase. You can put it into exercises like the bridge. I like to do it in the bridge as we're lifting the bridge up. So as you inhale to prepare, tilt up to lift the bridge, contracting in through your infinity join. Exhale as you lift the bridge. As you return the bridge, inhale and release your pelvic floor off. So it's not about holding the pelvic floor the whole way through the bridge. As you come up into the bridge, you exhale, draw your infinity belt in. As you come down out of the bridge, you inhale and you tilt it the other way. So the bridge is a perfect exercise to start to put it into. Now we're going to do the hip roll, which is really a hip hitch. So this is great on a stability ball, and you're going to get now a little bit of speed going with it. Now you can do it standing again, and what I want you to do is inhale to one side, exhale, draw up. Inhale, exhale, inhale, and then start to get some speed going with it. So you can do it on a ball, or you can do it seated or lying. Now we're actually going to do a hip hitch rather than a hip roll. So this time you're going to do it 8 times on one side. So now during the whole of that 8, I want you to keep your infinity point hitched. Hitch it, draw it up inside you, use your breath, inhaling and exhaling. Do 8 on one side and 8 on the other, and make sure during this that your core is engaged all the time. Excellent. So again, thinking about doing that in your prep phase, thinking about doing it in standing exercises. So if you do standing Pilates or any standing yoga exercises, you could do that before you do it. So you can start the exercise off, do something like the hip hitch, move into the exercise, hold the pelvic floor, move out of the exercise. The push we've done, that's just when you force out. The bridge we've done. Okay, side leg lift. So lie on your side. Lovely. Now, lying on your left side with your left knee bent, so bring that behind you. So knees stay in alignment. There you go. Okay. So now flex your foot into dorsiflexion. Now contract your pelvic floor muscles and raise the top leg down, up and down 5 times, staying contracted. So your focus is on your infinity point. Use your breath in both ways. Try and use your belly with it. Hold that contraction on the pelvic floor. And then release it and change sides. We're not going to change sides, but you can. So lying clam, I love the clam and pelvic floor work. So anytime you're doing the clam, instead of making the clam the focus, make the pelvic floor the focus. So lie on your back with your knees bent and drawn in towards your chest, and open both legs out to the sides as far as they will go. Okay, now this is a really good position to activate the pelvic floor. So let's, before we do anything, think about the infinity. Now if you want to here, put your feet into Pilates stance. So put heels together and toes out, because that will help activate the pelvic floor. Okay. Right, so as you inhale, contract the pelvic floor, bring it up inside you. Lovely. Now tilt your pelvis towards you slightly. So do a pelvic tilt. And then return your legs to center and release your pelvic floor. Inhale, engage pelvic floor. Bring your pelvic towards you, tilt. And as you exhale, release. As you inhale, sorry, as you release, inhale. As you draw towards you, exhale. Engage pelvic floor and release. So this is a really nice one. I think it's also a nice one because it kind of opens up the pelvis a little bit in terms of the hips and the pelvis itself, and still activates the pelvic floor. Do 3 sets of 5. Okay, now the breath oscillator, guys. Now, I'm not going to tell you what this one was called. I think it was called something like the pant. Okay, but we're going to call it the breath oscillator because we're doing pelvic floor work, not safe sex. So, sit in a comfortable cross-leg position with your spine nice and tall. So sit up through the spine. Now put your hands on your knees and close your eyes. Think about that infinity symbol. Now I like to try and go round the infinity symbol. So first try and contract around the infinity symbol and then come up through the middle of the infinity symbol and draw it up inside you. Now take a series of 15 short, fast inhales and exhales through your nose. So you've got to do it 15 times, holding your pelvic floor throughout. And then relax off. So again, think about when you can do that. I like doing this one towards the end of a class. Maybe when you then want to do a couple of seated stretches and you want to kind of put your hands up into stretches. Okay, happy with that one? So you're going to lie on the floor now and we're going to do the birth mother. Okay, I'm not going to tell you what this was definitely called in I think it was called something like the goddess position. So lie on the floor, bend both knees out to either side and touch your heels together, and then grab your feet and pull them towards your chests with your heels touching. The knees are still wide. Yeah. So that's it. So you're in this position. You can see Freddie's nice and flexible in that position. So now contract your pelvic floor, keep the heels touching and knees wide, and hold it for a count of 20 seconds. Take the knees as wide as you can. So what you really get as well is a really nice inner thigh stretch. And then the last one is to come into child's pose for me. So get into child's pose like you do in yoga, but your legs are like a frog. So legs are wide, okay? Knees as far apart as they will go. Now, rotate your pelvis forward, contract your pelvic floor. So pubic bone to belly button, effectively. Pubic bone to belly button, contract your pelvic floor. Hold it for 20 seconds, and then practice your breathing in that position. And practice your breathing in that position. Freddie's quite happy to stay there the rest of the day. Hold for 20 seconds and then release off and throw your pelvic floor away. And then do that again. So you could do that 2 or 3 times. Lovely. Well done. Thank you, Freddie. Beautiful model as always. Okay, guys. Would I use the same exercises for men? Yes. Yeah. Yeah, all of those exercises on my list are really nice exercises, and can you see how you can bring those into other exercises? So, and that's the key, is you don't want to necessarily spend 20 minutes of a session just trying to activate the pelvic floor. What we're trying to do is to get the pelvic floor to activate in everything else that you do. So what you want to do is to get that co-activation, because we know if we can get the pelvic floor activated, the information will go back through to diaphragm, it'll come back through TVA, and you'll get that whole neural activation of the deep stabilizing core rather than the global mobilizing core. So we have a tendency to move the global mobilizers without the stability of the global deep local stabilizers. With pregnancy, because that's all the global mobilizers, you're going to relax those off. You know, don't make the mistake of trying to do loads of abdominal work in pregnancy, because you're just wasting your time, because the abdominal is going to relax off. So it's got relaxing in the system, it's got to allow for the baby to come out the pelvis. But what we want to do is keep neural input and activation patterns to that deep intrinsic, and then allow everything to go back together in postnatal and allow that all to work together as a team.
A lot of these with older adults.
Yeah. So Freddie's saying, because Freddie teaches an older adults group where I think the youngest is 80, and you do a lot of this pelvic floor work with them as well, because they really appreciate it.